Hello guys, today we will talk about principles of surgical oncology. Topic of oncology is important topic because today have many types and many chance to treat cancer, and for surgeons it's important to know how we can help and what we have in surgery and what we have in other disciplines. Introduction. Surgical oncology focuses on the surgical management of tumors, especially cancerous tumors. Surgical oncology embraces cancer care in a multidisciplinary framework, internationally recognized as a standard of care for patients with cancer. It relies on coordination of surgery with medical and radiation oncologists, diagnostic specialists such as pathology and radiology, together with input from cancer nurses, allied health disciplines, and palliative care specialists. Surgical resection of cancer remains the cornerstone of treatment for many types of cancer. Historically, surgery was the only effective form of cancer treatment, but developments in radiation therapy and systematic therapies mean that optimal outcomes require multidisciplinary treatment, planning, and delivery in a team-based approach. Surgery plays various key roles in cancer care. Determine what role surgery has in a particular situation depends on accurate definition of the problem via preoperative staging, investigations, and multidisciplinary treatment planning. It is sometimes needed for diagnosis, is effective for various pre-malignant conditions or in situ malignancies, and is a central part of treatment for most localized malignancies. Its role in metastatic disease is limited, most often used when surgery can provide effective palliation by either together or preventing a specific local problem. Introduction continues. Communication with the patient and family, the obtaining of informed consent, and the careful, honest, realistic, but where possible, optimistic explanation of the results of surgery are all matters of high importance to all surgical practice. However, the ability to talk sympathetically to cancer patients and their families is particularly important in the field of surgical oncology. Clinical trials are required to evaluate new treatments and treatment combinations. There has been a huge amount of basic cancer research that continues to provide new insights. Translating these basic findings into clinically meaningful management is a major challenge and is a key aspect of the discipline of surgery oncology. Now we will talk about multidisciplinary care. All clinical disciplines involved in cancer care must understand the principles and practical consequences of the treatment offered by surgeons, radiations, oncologists, medical oncologists, and the allied health disciplines, in order to be able to work in a team to care for cancer patients. Radiation oncology. Radiation therapy may be delivered along with curative intent in some cancers as an adjuvant therapy to reduce the risk of recurrence in many situations, and frequently as a palliative treatment, for example, of painful bony metastasis in breast and prostate cancer. Effective symptom relief is often achieved with the use of radiation therapy. Radiation oncology involves the use of ionizing radiation to selectively kill tumor cells. Radiation kills living cells by both direct DNA damage and the formation of free oxygen radicals in the cells. Free radical formation is the predominant effect and depends on the level of oxygenation of the tissue. Radiation. Ionizing radiation is usually delivered to tumors as external beam therapy, generated by linear accelerators. When a linear accelerator is used to supply external beam therapy to a tumor, the patient goes through a series of planning exercises to accurately delineate the tumor and direct the radiation as accurately as possible to the tumor to minimize the impact on normal tissues. An alternative method of administration of radiation is by using a local radiation source applied close to the tumor. This is known as brachytherapy. It's a highly effective form of therapy in tumors such as cervical cancer, other gynecological cancers, and prostate cancer. Both normal and neoplastic cells are affected by radiation, so the dose which can be given in any situation is limited by the tolerance of the surrounding normal tissue. Tissue particularly at risk include the bone marrow and gastrointestinal tract, which contain rapidly dividing cells. Of course, the spinal cord is also at risk as it does not have repair mechanisms able to manage radiation-induced injury. Normal tissue can recover from radiation provided the dose is not extreme, while malignant cells repair such damage less well. Fractionation of radiation, splitting the total dose into multiple daily low doses, allows normal tissues to recover better between those doses than cancerous cells or tissues, allowing better selectivity of the impact of radiation. Medical oncology. While surgery and radiotherapy are local treatments, they have their impact by treating the tissues that are removed or radiated. Many cancers have disseminated around the body at the time of diagnosis. Systemic treatment are needed to address this, and its improvements in systemic therapy of cancers that have had the biggest impact on outcomes over the last 20 years. Medical oncologists use a variety of agents to modify tumor growth. Many of these are cytotoxic chemotherapy drugs that are toxic to dividing cells. Others are endocrine therapies that target the cellular pathways related to hormones. For example, tamoxifen and the others are endocrine therapies. No? Tamoxifen and the aromatase inhibitors in breast cancer are the best examples of this, while others are biological therapies that have been developed to modify some aspect of cellular function or to modify the immune response to a cancer. Some cancers can be cured with systemic therapy alone. Many lymphomas and other hematological cancers and some testicular tumors are such examples. However, these are the exceptions, and for most solid tumors, systemic treatment alone produces a limited or partial response. Many randomized controlled clinical trials have demonstrated a survival benefit from the use of chemotherapy and other systemic therapies when given as either neoadjuvant, we call it preoperative, or adjuvant, we call it postoperative therapy. Adjuvant therapy is treatment given in the absence of known disseminated disease in order to reduce the risk of subsequent emergence of metastatic disease. Breast cancer and colon cancer are two cancers where landmark clinical trials have demonstrated significant improvement in survival with the use of adjuvant systemic therapy. Subsequently, effective adjuvant systemic therapy has become available for a wide variety of cancers. In cases of disseminated disease, where cure is not generally possible, systemic therapy forms the basis of treatment with surgery and radiotherapy used to address specific problems. Supportive care. The holistic approach to the care of the cancer patient encompasses a range of supportive and coordination services through and treatment phases. This is often delivered by a range of nursing and allied health professionals. Physiological support includes investigation and treatment of cancer patients by suitably trained nursing staff, social workers, psychologists, and psychiatrists. Each discipline can offer some support depending on the problem faced by the cancer patient. A nurse coordinator often aids in the management of the patient. The use of such professionals has been shown to improve outcomes for cancer patients. The cancer survivorship is a concept that has become prominent over recent years, as the includence no, mm, as the incidence of cancer has increased along with the aging population and cure rates for common cancer have increased, there is an increasing number of people who have apparently been cured but are left with uncertainty, uncertainty um, regarding the chance that the cancer will recur and may be suffering morbidity from the cancer or its treatment. This disease should be directly addressed at the end of active treatment, where patients are ready to move to a long-term follow-up phase of care. General practitioners and other primary care practitioners are well placed to manage many of these issues. Palliative care. Modern palliative care programs are part of the services offered to cancer patients in whom cure is not possible. These services include ambulatory and hospice programs for management of the end stages of life when attempts to cure or actively treat the cancer have ceased. Physical and psychological symptom control is an important part of modern multidisciplinary care. Palliative care physicians also help in pain control and symptom control in the earlier stages of the illness and thus broaden their influence in the journey of the patient with cancer. Early involvement of palliative care has been shown to improve both the quality and also the length of life of many cancer patients. Principles of surgery for malignant disease. involves screening and diagnosis, assessment of the patient, staging of the extent of cancer, decisions about treatment by the multidisciplinary team, principles of operative surgical oncology, rehabilitation, and follow-up. Each of these will be dealt with in turn. Screening and diagnosis of malignant disease. Randomized controlled trials of the population screening have shown survival benefit in a number of diseases. For screening to be effective, the test must be able to detect a common cancer at a stage where treatment is more effective than treatment given when a cancer becomes symptomatic. The test must be sensitive, specific, and acceptable to the public. The most effective screening program has been cervical screening, where since its introduction there has been a substantial fall in mortality from cervical cancers in all age groups. Recently, the pap smear is being replaced by an assay for human population (HPV), and this should dramatically improve the already very good outcomes. Similar, less dramatic effects as seen with breast cancer screening by mammography and colon cancer screening using fecal occult blood testing and follow-up colonoscopy. There we see a picture with new breast cancer screening guideline for women with average risk, and we see in what age they need do any types of screening. Population screening for prostate cancer using prostate-specific antigen (PSA). Testing remains controversial due to the potential morbidity of prostate cancer treatment and the inability to distinguish indolent from aggressive cancers. As these problems are addressed, evidence around an optimal approach to prostate cancer screening is likely to emerge. Diagnosis. A tissue diagnosis is essential prior to the creation of a management plan for cancer patients. The consequences of many cancer treatments are so severe that only rarely can treatment be commenced without a pathological disease. Tissue is obtained by fine needle aspiration, core biopsy, or excisional biopsy. Percutaneous biopsy. Fine needle aspiration, cytology, and core biopsy can be done on an outpatient basis and provides a rapid diagnosis of accessible lesions such as breast lumps, head and neck lymph nodes, and thyroid thyroid swellings. Ultrasound guidance for the biopsy needle is necessary and commonly used. CT or MRI guidance may also be used. Endoscopic biopsy is the basis of most diagnoses of upper and lower gastrointestinal cancers and lung cancers. All these techniques rely on the expertise of the pathologist to make a definite diagnosis on the basis of either the cytological or histological characteristics of the tumor, supplemented by a variety of immunohistochemical assays to accurately define the tissues of origin and assess its likely natural history and response to particular treatments. Where local mass or skin lesion can be completely excised without significant morbidity, excisional biopsy is the treatment of choice. Removing the problem at the same time as making the diagnosis. This technique is commonly used for skin lesions, particularly suspected squamous cell carcinoma, basal cell carcinoma, and melanoma. Sometimes excisional biopsy or incisional, where not all the lesion is removed, of a deeper lesion is required when attempts to reach a diagnosis in a less invasive manner have failed or are too dangerous, or when then lesion should be removed for cosmetic or other reasons. Assessment of the patient. An important early part of the assessment of a patient with cancer is to determine health and fitness and ability to tolerate various treatments with acceptable risk of complications. Many cancer treatments are demanding on the physical and psychological resource of the patient. An idea of the health of the patient can be gained from a simple clinical assessment, the Eastern Cooperative Oncology Group or ECOG performance status, with more complex assessment needed prior to more intense treatment. Accurate staging of the extent of disease is of great importance in formulating a treatment plan. Clinical stage is defined by clinical examination and imaging of the patient. High-quality imaging has led to improved accuracy of clinical staging. Pathological staging is defined after excisional surgery. Classification T and M. The most commonly used staging system is the tumor nodes metastasis system. The American Joint Committee on Cancer defines the TNM staging for all cancers. Suffixes to the TN and M indicate the size of the tumor and extent of nodal disease or metastasis. For example, T2 N1 M0 indicates the stage of a tumor, for example carcinoma of the colon, where the tumor has spread into the muscularis propria but not through the wall of the colon, T2, and where there are agents lymph nodes involved, nodes 1, but no metastasis detected, metastasis 0. Combination of T and N stages are grouped into overall stage with similar prognosis ranging from stage 0. Indication premalignant disease, ductal carcinoma in situ of the breast, to stage 4. Indication metastatic disease. The staging system varies dramatically according to the primary site of the tumor. Recommendations about treatment. Armed with information about the diagnosis of the cancer, the extent of the disease, and the fitness of the patient, recommendations and decisions can be made about the most appropriate treatment program. Consultation with a multidisciplinary team may occur prior to surgery. However, if the decisions regarding surgery is straightforward, the multidisciplinary meeting may occur after surgery when full pathological information is available. However, many cancers may benefit from downstaging with radiotherapy or chemotherapy prior to surgery, and early multidisciplinary consultations are important to facilitate this process. Principles of operative surgery oncology. The technical issues in surgery oncology are no different from other surgical interventions. Open surgery, laparoscopic, robotic surgery, ablative interventions, and other technical interventions all have a place in modern surgical oncology. However, some important oncological principles exist which must be followed by the surgeon for a satisfactory outcome. Definition of curative surgery. So-called curative surgery generally involves an apparent total excision of the tumor, the primary tumor, and the associated lymph node drainage fields are often excited where nodal involvement is known, suspected, or reasonably likely. A measure of the adequacy of the oncological surgical operation is demonstrated by the findings on pathological examination of the specimen. Standards exist for ensuring the adequacy of the surgical excision to be assessed in many tumors. The operative specimens need to be correctly oriented by the surgeon to allow the pathologist to carefully examine and interpret the specimen. The key cases are usually: first, the precise histopathological of the cancer including relevant tumor markers; second, whether the margins of the specimen removed are clear of tumor; and third, the total number of lymph nodes excited and the number of involved nodes. A major focus of modern cancer surgery has been the preservation of function. Improved surgical techniques and effective use of multidisciplinary treatment has resulted in diminished morbidity of major cancer surgery. Examples of this include larynx-preserving treatment for head and neck cancer, limb-sparing surgery for soft tissue sarcoma, and sphincter-sparing treatment for rectal cancer. Margins of surgical excision. The degree to which normal tissues should be removed with the primary tumor is a subject constantly being researched. A universal rule is not possible to formulate. The principle of complete local excision with an adequate margin is paramount in surgical oncology, and many trials have helped clarify what adequate means. It varies significantly according to the cancer, its natural history, and the availability of effective adjuvant therapies. Lymph node resection. Traditionally, the draining lymph nodes from a primary tumor were excited with the cancer. The main benefit of this removal is improved prognostic information, which may affect the decisions regarding postoperative adjuvant therapy. In some situations, there may be a local control or survival benefit from removal of early involved lymph nodes. The extent of lymph node surgery has reduced over recent decades. This is partly due to the recognition that prophylactic excision of uninvolved nodes does not provide a survival advantage to the patient and exposes the patient to increased morbidity from the node removal. It's also due to the introduction of lymphatic mapping and sentinel node biopsy, where the first draining lymph node can be identified and removed, giving prognostic information without a great risk of morbidity and allowing better informed decisions regarding further nodal surgery. Palliative surgery aims to improve quality of life by either preventing or avoiding some symptom-producing consequence of the tumor by resection or bypass. This is done even though a cure is known to be impossible. Examples include the following. In the case of pyloric obstruction from an advanced cancer of the stomach, a gastroduodenostomy may provide good palliation of vomiting. Resection of a bleeding cancer of the colon is justified even in the presence of metastasis. Many other examples exist. Tailoring this type of surgery to the needs of the patients without undue morbidity is an important role for an oncological surgeon. A program of follow-up is required for cancer patients after their initial treatment. This is for two main reasons. The first is monitor and investigate when appropriate to detect recurrent diseases. In general, early diagnosis of symptomatic recurrence is appropriate as it allows the most effective palliative treatment. Whether imaging to detect asymptomatic recurrence disease is appropriate depends on whether there is treatment for the recurrence that is more effective in the asymptomatic phase. Early detection of liver metastasis after colorectal cancer treatment is appropriate as cure may be possible when appropriately staged patients with liver metastasis are successfully resected. On the other hand, detection of asymptomatic breast cancer metastasis has not been shown to be beneficial, and therefore routine surveillance CT and bone scans are not done. However, screening for asymptomatic new primary cancer is performed. The second reason for follow-up is that it provides an opportunity to identify and manage side effects of the disease and its treatment and to support the patient psychologically. Increasingly, it is recognized that severe physiological morbidity may exist in cancer patients who have been treated even if the cancer is apparently cured. This has led to a developing interest in the concept of survivorship, understanding the needs of the cured cancer patient. Psychological support is essential for many cancer patients and is best delivered in the setting of multidisciplinary care. Clinical research is essential for evaluating new and previously untested treatments. Surgeons are involved in a number of ways. Provision of tissue for tissue banking. This is a fast-growing program throughout the world. The provision of fresh tissues for genetic studies is of paramount importance to the understanding of malignant disease. Collection of accurate clinical data to accompany the tissue invaluable. The second one, surgeons design, implement and run clinical trials to assess new surgical approach to cancer. The recruiter for randomized clinical trials must have equipoise in relation to the arms of the study and be able to assure the patient that there is no reason why he or she should not enter the trial, as current knowledge does not suggest that one or other arm is clearly better. The surgeon operation on cancer patients in the 21st century must have a deep understanding of the malignant process to be prepared to work as part of a team and offer multidisciplinary care. Communicate well, operate with a high level of skill, help the patient rehabilitated from the treatment, and finally be involved in the advancing area of surgical science as applied to cancer care. Thank you for your attention. Join me in Instagram.